Good afternoon then, and welcome to day 2 of the Postgraduate Research Festival with the theme of Civic Researchers in Action. We had a great day yesterday, lots of talks, lots of networking and interaction. I'm sure today is just going to be as good. So in terms of today, we've got a keynote speaker, there's going to be some refreshments, and then we've got UGS discussions, which is just for the postgraduates only. And then finally at 3:45, we're going to have our awards ceremony and the drinks reception. So it's my pleasure to introduce our keynote lecturer today, Professor Andrew Beggs, who is Professor of Cancer Genetics and Surgery. And Andrew's going to be discussing his civic contribution during the global pandemic and COVID-19. And he's going to talk about new methodologies developed, working with industry, and how our research has changed because of the pandemic. So I'll hand you over to Andrew.
Get this on. It always amplifies you up, doesn't it?
So hopefully you can all hear me. Well done for coming. I walked over from the medical school and I thought I was going to melt before I got in. So I'm not looking forward to going back. I thought it was a bit lazy to drive the car. So I'm Andrew Beggs. I work in the medical school and I'm a surgeon. That's if it sounds like I'm going to a confessional, I'm a surgeon, I'm from the medical school. But actually I'm also a scientist. I like to joke that I'm a scientist with a special interest in surgery, which makes people even more worried about having surgery under my care. But I'm going to talk to you a bit about some of the work we did with COVID-19. And how I got into COVID-19 is I, amongst other things, run the molecular genetics core facility in the university. And when COVID first started in 2020, it became very apparent, I'm trying to be diplomatic because it might be recorded this, it became very apparent the NHS was not ready for testing people for COVID-19. And our lab, and this is cutting, I haven't been prepared slides on this particular bit, but we transformed our genetics facility into a qPCR testing lab for COVID, which could do 10,000 samples a day. And at one point we were doing all the testing for all of the West Midlands, for all the hospitals, paramedics, nurses, community testing. We only had to do that for a couple of months to fill in. But it allowed me to, and this is the important part about civics, you never know what you're going to get into. And what it allowed me to do is get contacts with the government, with industry, and allow me to develop some other things around COVID-19 that I'm going to talk to you about today. It also led to me meeting Boris Johnson and Dominic Cummings, neither of which are very good, you'll be pleased to say, but I can say I have certainly had an interesting life for having met them both, especially the video conference with Dominic Cummings, which was a very, very strange experience, to say the least. So one of the things, I already had some existing collaboration, but one of the things it has done, there are going to be lots of terrifying slides in this, but it's not a lecture about molecular genetics or supramolecular chemistry. I saw some posters outside who has done that, or AI models in cancer. But one of the things it has brought is brought us all a lot closer together, and I've ended up working with a lot of people I wouldn't expect to, vis-a-vis Dominic Cummings and Boris, and various Matt Hancock until he got sacked. I haven't met Sajid Javid yet. So it gave you and Chris Whitty and the CSO, I never would have thought I would have met any of these people, but it gave you a unique insight into their world and actually made a surgeon very much more sympathetic to the civil servants that work in government and realize it's not quite as easy as you think it is to enable a lot of these things. So I'm going to discuss two of the things we did today, RTF-XBAR, which is something we did with the School of Chemistry, and Magnify, which is something we did with NHS Digital and a collaborative partnership. Now, if you're into science fiction like me, that's HAL 9000. He was in the book 2001: A Space Odyssey and the film. Intelligent computers, and it's always been the dream, AI. And what we were asked to develop by the government because of our links was an AI reader for lateral flow devices. So I'm almost certain everybody in the audience would have a lateral flow device. If you haven't, then you've probably been on another planet for the last 2 years. But one of the things you'll know about lateral flow devices are they are difficult to use. You know, you do the swab and then you put the thing on. Every different lateral flow device comes with a different type of way of doing it. And then you sit there and you're feeling poorly or not feeling poorly, as the case may be, and the band's develop, and you're looking at them and you're going, is that positive? Is that negative? Can I go and see a granny? Can I stay at home? What can I do? And one of the issues there, it was one of the things we found, it was very difficult to interpret lateral flow devices for a significant segment of the population. And it wasn't who you would think. The worst people at it were GPs, interestingly, when we did some preliminary research. So don't get too worried about all the detail, but because I use the same slides for everybody because I don't want to forget anything. But essentially, one of the things we showed is that when you looked within healthcare workers,
if you got them to look at the lateral flow device and tell you what they thought it was, and then if you got an expert, we have an expert panel in the medical school of 4 people, including myself, who looked at it honestly, there was a difference in accuracy. In fact, people only got their lateral flow device read right about half of the time, 52%. Whereas when we looked at them as the expert panel, who were trained on over 1,000 lateral flow devices, we had some positive controls, it was 78%. And this is due to lots of things. I mean, it may be something as simple as some people, bad light. So a lot of people would look at them in bad lighting, you know, dark, you can't really tell. Some people like me, I'm as blind as a bat. It's the other thing I don't tell patients. I'm so short-sighted, I get free eye tests. So I don't tell patients their surgeon's partially sighted because that never goes down well. But there's simple things like that. But the reason it was important to do lateral flow devices, because there was a lot of controversy about whether they're any use or not, was actually the Liverpool asymptomatic pilot was called. So that was carried out in communities in Liverpool, hard to reach, deprived communities in Liverpool, showed that lateral flow devices did break the chain of transmission and reduce the passage of COVID, reduce the R number. So we wanted to combine the fact that an expert human could tell better whether the lateral flow device was positive from a lay human. So we decided to build an AI lateral flow device reader, and this was commissioned by the government. So we'd come to their attention because of our work with COVID at the beginning. And then sometimes it's as simple as making that introduction between people in government. And so I got a phone call from the Department of Health saying, would you be interested in working on being the chief scientist on this project? So I'm the chief scientist for this project. So we wanted to make it better than humans using a machine learning model, so AI. If there's any mathematicians in the audience, you'll know that AI is basically just logistic regression, but we needed something that worked and was reproducible. But the most important thing was to increase user confidence, because, you know, once again, you're not sure whether your lateral flow device is positive, and anxiety. But almost more importantly, if you worked in the healthcare system and you did a lateral flow device, you were meant to report the result back to your employer. Only 10% of healthcare workers did that. And so by having to take a photo of the lateral flow device, we tracked you with the QR code on it. You will see, yes, the government is tracking you. We didn't know who you were, but we knew where the QR code should be coming from. We could hopefully reduce the transmission rate of the virus. So the way we did it is we got a load of pictures, and for that Liverpool pilot that they carried out in socially deprived communities in Liverpool, they took photos of literally every lateral flow device that was taken, then they compared it with a PCR test. And then we trained the AI reader to say, is this a positive test or not? And we also did a series of lateral flow devices where we got virus, we grow it. Another thing we don't tell people at Birmingham, we're growing COVID upstairs in the IBR building, for 5th floor. Don't go there if you don't like it. But it's very safe, trust me. We've got all kinds of interesting things up there. Not smallpox, for those who know that story from 1978, or monkeypox yet. But we grow virus, we put it on the lateral flow device to test the reader, to train it up. And then we rolled it out into 2 pilot sites, asymptomatic testing sites that some of you remember from way ago, where you would go to a testing site, they would give you a lateral flow device, you would do it, they do the swab, they would read it for you. And we took photos, including here as well. And we also did it with self-reports and lateral health and social care staff. And the algorithm then decided whether it was positive or negative. And then the ones it disagreed on, we would then go back, and our trained observers, which was me and 3 of my postdocs, sat there and looked at it. And in the end, we looked at about 10,000 discrepancies, which was quite a lot of work, but we didn't have anything else to do because all the hospitals were shut down. So once again, don't worry about the figures. It's more just to demonstrate things. So this is ATS. So this is the expert when you used to go to, say, the university bit here and do your lateral flow device, versus our AI algorithm. So actually there's pretty good concordance. We looked at about 58,000 lateral flow devices. The accuracy was pretty good for our algorithm. So we could say it was pretty much equivalent to an expert interpreting it at the asymptomatic test center. When we did the ground truth, i.e. my experts looked at it, we found actually even the AI algorithm was still better than having an expert read it in the community at these asymptomatic test centers. So the AI reader worked better for this. So that was good to start with, but that wasn't the issue, because most people didn't do lateral flow devices at these test centers. You didn't all go out, you did them at home. And so we then moved on to people taking a photo of their lateral flow device with their phone. It would upload to the NHS website, the QR code would link it, and then it would ping and tell you within 3 seconds whether your test was positive or negative. So when we did that, this is what, you're gonna look at this and say, this is terrible, Andrew, how did you ever release this? This has just been accepted for publication actually in Cell. How's this terrible, Andrew? Well, self-report is what the person thought it was. And magnify is what we thought it was with the algorithm. And you can see the sensitivity and specificity are terrible, 16%. That means just over 1 in 10 we were right. And we were thinking, oh God, we've made a terrible mistake. You know, our AI algorithm is terrible. This is the problem with AI algorithms, they're not reproducible. But then when we went and looked at the ones that they disagreed about with our expert truth, we actually found the algorithm was much more right, was completely correct. And the people who were wrong were the people who were doing the self-report. Alarmingly, it wasn't, we talked earlier about how people only get it 50% right at a time. We found that healthcare workers were only getting it right 1 in 10 times for positive tests, which is slightly alarming when you think about it, and probably explains a great deal of the transmission in the pandemic. And so our algorithm for looking at lateral flow devices showed that you can massively increase the accuracy by using a simple AI reader. Now, you may not believe me, and you think, how can people be so stupid not to interpret lateral flow devices? Here are some real pictures where we've blanked out the LFDs and the people to save the innocent. We received images from all over the country. We received some quite alarming images, including one naked man on the toilet who took a photo of the lateral flow device on his knee, some hideous carpets, some really dodgy interior decoration choices, and people like holding up to their faces and pointing like that. The algorithm is meant to actually only recognize a lateral flow device if it's a neutral surface. But as you can see here, where people have written plus on it, these are ones where people thought they were positive. Now, you may not be able to see very well, but trust me, they're not positive at all. In fact, none of them are positive. There are no positive bands there. So these are false positives. The end user thought they were positive, but they actually really weren't. And we had these, the other thing about these photos is we had them all in very high resolution, Ultra HD, whatever, so we could zoom right in, we could do image analysis, we could do enrichment, just to make sure we weren't missing anything. They were definitely negative. And they all had PCR as well in the end. Now, these are false negatives. Now, you may not be able to see some of them, but some of them you can probably see there's clearly a band, like on the bottom, second from the left, there's definitely a band there. And these are being reported as negative by people. And my wife is a social scientist at Warwick, so she insisted we had to do this is how research works. We had to do a sort of mixed method study to understand why people were calling these negative. And a lot of it's to do with the fact that people don't want to have COVID because they've got something else to do. And so these, which were clearly positive here, were being reported as negative because it wasn't very strong. Or I didn't think that meant anything. I mean, that one on the top right is ridiculous. We didn't get an explanation for that, but apparently the person thought that was negative. And so, but the advantage of the AI reader is it allows you to sort of quality manage, quality control these things. So this is to show you what it looks like on the Nhs algorithm. Until the COVID pandemic started to get better, the plan was for everybody in the country to use this, and it's ready to be switched back on if we needed it, if there's a second wave back. At the moment, healthcare workers are using this every day. If you're a healthcare worker and you have to report a lateral flow device, it will, when you log into the portal to do it, which you can see here, it will ask you to take a photo of the device and it will report it. At the moment, we're returning about 100,000 tests a day on this. At the peak, we were returning about 1 million tests a day at one point. In 3 seconds, we rolled it all out into the cloud. But this is already, it's sitting in the background, ready to be switched back on if there's another outbreak in the winter. And we did show, I haven't got the data here because it's pre-publication, but we did show it broke chains of transmission. And actually, we're pretty sure that one of the reasons COVID has gone down recently is because of this reader. We saw definite drops in incidence and onward transmission in areas where this system was activated. So it shows that, you know, just having this kind of device and the impact it generates allows you to really cause a change. And it's been going since last year, you can see. And you can see at the moment, this was from ages ago, this slide. You can see at that point, we've done 1.7 million reads. I think there's something like 12 million now. So we've used this 12 million times. Now, one of the things you may say is, what about the cost, Andrew? You know, the billions we spent on COVID. This cost 6p to run. So 6p times a million, yes, it's a lot of money. 600,000, I don't know, however, 60,000, but it's still very cheap for the amount of accuracy it gives. One of the things that people don't know is how much lateral flow devices cost. This is, I can say this now because the contracts are over. How much do you think a lateral flow device costs the government? Think about how much you've paid if you ever bought one to go overseas. Any ideas? You can shout out. It's not a lecture, it's just like a friendly thing. 40p. Well, P. Well, actually, no, it's not. I was hoping people were going to go the other way. It's actually £1. It costs the government £1 to buy a lateral flow device. But if you buy them over the counter, they cost about £5 each. So the contract cost was about £1 for lateral flow devices. So £1 plus 7p is not a lot of money to improve diagnosis. So we did a cost, because it's government and because there are people in the Department of Health and Social Care who love doing this kind of stuff, they did a cost benefit analysis for us. And they showed in the end, actually, we had greater than 50% sensitivity increase. So if you did for every 2 million tests reduced by another 1,500 infections transmission onwards, and that would save the economy 2.4 million per million tests. So it actually paid for itself, which is another sort of benefit to it. So one of the problems is there was a lot of adverse press about lateral flows. So there was a there was positive lateral flow and negative PCR test. That turned out to be the lab in Wolverhampton that was not doing it properly, the PCR testing, because they were basically throwing them in the bin. And then the lateral flow tests were right. It's very difficult to get a positive lateral flow, actually, unless you've really got COVID. And then the PCR test false negative, that's the lab in Wolverhampton again. But then everybody going, lateral flow device is terrible, we don't want to use them. But then when the government was going to take them away, everybody was saying, oh no, we don't want to run the free rapid test. And that's a Guardian page. That's one of our lateral flow devices that we sent them to put on there. And then actually they found that when we found and others have found is that lateral flow devices are actually a really good proxy for infectivity. So although they may not always be positive if you're PCR positive, if you have a positive lateral flow device, you're very likely to be infectious, which is quite a useful thing to know. So this reader helped us, we realized the reason it was so effective is because it broke the infectious chain of transmission. So it outperformed human readers. It had more true positive claims. We also had some void and fraudulent claims. I can't say what branch of the government they were from, but we had some people who drew red lines on their lateral flow devices to go off sick. And that was caught out by the reader. The reader has a fraud detection algorithm. We had people who broke the devices open, draw things on them and put them back in. We had people who broke open the devices and put a friend's strip in who was positive and closed the device. And we detected all of those successfully. So this has allowed us to sort of reliably track the transmission. The other thing we've done, for those who are interested in process, we've actually got it CE marked. So this is the first CE marked lateral flow device reader anywhere in the world. Unfortunately, I don't hold the IP, because if I did, I wouldn't be here talking to you today. I'd be on a Caribbean island. But it's good to know that the university could be involved with doing this. Now, the final thing I'm going to talk about very quickly is stuff with the School of Chemistry. You may see the wonderful Haworth building there. I believe Jim Tucker et al. Are getting a beautiful new chemistry building very soon in Mold Sciences too. And there's his group there. We work with Jim and us and Tim DeFawn in Biosciences on this. And I'm not going to go into loads of details because this will make your eyes glaze over after lunch. But basically, PCR tests are slow. You've all done a PCR test, I'm pretty sure, in the room at one stage or another. It takes at least a day to come back. When we do them in my lab, the quickest we can do them is 3 hours. And that's from extraction of the swab to PCR result. And it's very sensitive, but it's very, very slow. And the PCR machine is about this big. You can't really carry it. It's not very portable. So Jim and others and ourselves wanted to come up with a quicker test to develop a fast operational test. This has been published in PNAS, which is a reasonably good journal, but something we can drop into other instrumentation so we can increase capacity and quickness. So it's called XBAR. It's been patented now. The patent's been awarded, so I can talk about it in public. And it's a way to amplify nucleic acid very quickly. Now, I won't go into loads of details because I know we've got a mixed audience, but a SARS-CoV-2 is an RNA virus. You have RNA and DNA. And to detect RNA, you have to convert it to DNA. And that's the thing that slows it down. So the XBAR test doesn't need to do that conversion. It can just detect RNA natively. It can do it very, very quickly. Whereas a PCR reaction takes 90 minutes to detect, this can work in 10 to 20 seconds. And even with very low viral loads, it can do it within 5 minutes. So I'm not going to take you through the entire thing. But basically what this shows is with different loads of viral loads, you can detect COVID very quickly. In fact, if you can see on the blue, you can see the peak already starts to go up at less than 1 minute. And that was with a sort of normal dose of COVID that you would have. And we use a fluorescence output to detect that. We can use it for other things as well. And just to prove it wasn't a one-off, we did it on real SARS-CoV-2 RNA from patients, and we showed that you could easily detect positive and negative. You may say, well, why is there a negative curve there? The reason there's a negative curve is the dirty secret of nucleic acid amplification is that if you leave it for long enough, it will generate a signal. That's PCR, LAMP, XBAR. And so it worked, basically. And it's been bought by a company. I can't say which yet, but a company has bought it. So there's Impact for Birmingham. And it works at different doses. These curves here that show as you get different doses of SARS-CoV-2, you still detect it, which is really great. Oh, I've never done that before. And then the final thing we did was take it to a patient panel. And so the blue here are the negative and the red is a positive. And generally, although we have changed it since then, you can see a quite substantial difference. The ones that looked positive but were negative on here were in fact ones that only had one of the COVID genes. We detected 2, but had only had one of the COVID genes. So it's difficult to know whether they're positive or not. But essentially, the long and the short of it is we show that this novel chemistry was just as accurate as PCR, took 30 seconds to work instead of 90 minutes, didn't need an RNA transformation step, and could be dropped into any assay. And this has been bought, it's being commercialized, and we're using it for other things. So for civic impact, this COVID is going to be a problem, but not as much of a problem as other diseases. At the moment, we're turning this into a HPV assay for liquid cervical cancer screening in lower income countries for women who suffer from poor access to it. And that's the kind of thing you can take this test and use it for other things. It's got so many versatile uses. And the other thing we're going to be using it for potentially is bioweapons detection, bacterial, things like anthrax, because it's so quick, it can give people on the battlefield a very quick idea of what's going on. So and that was basically me emailing Jim Tucker and Jim and Tim DeFawn and going, yeah, let's do a COVID test on this chemistry. And they went, yeah, let's do it. And they spent about 20 minutes designing it. And then we ran it 2 days later and it worked. Sometimes science is just lucky. But it's a 3-minute assay. It's accurate as PCR, multiplex, and it's very cheap. The other thing is it's not a special chemistry where you need to buy a fancy thing which needs to be manufactured. This was all off-the-shelf reagents that we can grow in vats. And you can detect it any way you like. In fact, Jake, who's the PhD student working on it, who's now got his PhD. He was the one who did most of the work for this. He was on the telly as well, so he loves it. He developed a colorimetric one where you could actually change color depending on whether you had COVID or not, between yellow or red. So that's the lab. We're funded by a lot of people, including the BBSRC. And it's a multidisciplinary team. Can't do it without funding, but we can't really do it without working in a place like Birmingham, which is a proper civic university. And that's it.